Hi everyone, I'm Dr. Sasanka. I'm a urologist at KIMS Kondapur, and I thought I'd take this opportunity to talk to you about kidney stones. How do they present? What can we do about it? Do they cause trouble? When do they cause trouble? And how do we prevent it? So, as quite a few of you are now aware, kidney stones are indeed one of the commonest complaint issues which are present in a lot of people. Quite a bit of the population, especially typically the younger 20s and 30s, they are the ones who actually land up in trouble because of kidney stones. You have to understand that now with so much of information, a lot of people do know that they have a stone and they have that kind of pain that it usually does cause. But I might as well just explain to you how a kidney stone patient typically presents with. Now you have to understand that a small stone actually might not cause so much of damage and yet can cause a severe pain. The worst pain in the world is probably due to a stone that is moved down from the kidney into the ureter. The ureter is a very standard tube. It's a hollow muscular tube that conducts the urine from the kidney down into the bladder. And if a stone is present in the kidney, it might not cause so much of a pain. On the other hand, the day the stone decides to move down into the ureter, that's the day that the patient actually experiences very severe pain. So with the advent of information, a lot of people do realize that how pain can be. But broadly, most of the patients that we do see come with complaints of pain that starts typically in the back, one side of the back, like we call it the loin region. And when it comes from the back, it usually comes forward as well towards the lower abdomen. And sometimes it might radiate down to the groin or the scrotum area. Now, when the pain comes, as I said earlier, it could be excruciating. It is what is typically called colic, where it's an episode of a pain, then there's relief for about a few minutes, and then again the pain starts. And often the pain is associated with some kind of a vomiting or nausea. Some people say they have fever and chills and ideas. All these are important. Some people say, Doc, I used to pass urine earlier very comfortably. Now I feel like going to the washroom every 5 minutes, but nothing really comes out. These are the common features. Some people might say that they notice blood in the urine. Some people will recollect that yes, we did have this kind of a pain earlier. That time I had a relief after the small stone like particle came out. And yes, they do realize now that this is a stone that has come back again. On the other hand, you also can have the other extreme where a patient might have such a severe pain and pain can be caused. And you have to realize that it need not necessarily always be due to a stone. So the stone, if not pain, what else can it be? Sometimes there's something called a papillary necrosis, which could cause this kind of a pain. There's a small meaty particle that comes down from the kidney, especially in diabetic patients. Usually it's associated with high-grade fever and chills and radius. But again, unfortunately, it causes a fairly high distress for the patient. And also, these need to be tackled as an emergency basis. You also have to realize that not all stones can cause pain. In fact, that's the unfortunate part. The small stones which actually cause severe pain usually manage to come out and the kidney is usually well preserved at the end of the episode. But the larger stones which actually can cause significant kidney damage, they could be silently growing. And sometimes they can be brought to the attention of the urologist by the patient when he says, Doctor, I had this health checkup done as a part of my routine annual screening. And they say that, look, I've got a 15 mm stone sitting inside the ureter, but I never had a pain. And unfortunately, yes, that does happen. The larger stones actually tend to get impacted fairly early, and they cause silent swelling of the kidney. And unfortunately, sometimes the kidney function can be so deranged that even removal of the stone might not really improve the kidney function very much. So it is important that a patient, even if he has a mild pain, does get evaluated for that, confirm that there's no real obstruction to the system. Having said that, let's say we have now a young male, typically a 30-year-old man. He's reasonably well educated, but he's sitting at home for the most part. He's hardly taking even 1 liter of water through the day. Now he's come to my emergency room. The hospital where I work is KIMS Kondapur, and he's now come to the emergency room, and he's writhing in pain. And what we do give them basically an initial pain management medicine. Now, the commonest medicine that we do prefer is something like a Buscopan or a Clemzac. They are safe even in the presence of deranged kidney function. They don't really cause so much of a issue and usually give reasonably good pain relief. There are medicines stronger than what we can give right now, but we would rather get the reports and then confirm that we are dealing with a stone and confirm that the kidney function is okay before we give any stronger pain medicine. Okay. So now the pain is relieved, patients is talking now what, and that's when we come to the picture. Uh, the best test is still CD abdomen. It is a very commonly available test nowadays, especially in the urban areas and even in tier 2, tier 3 cities. CT scan is now not as difficult to get done as earlier. And what is the advantage of the CT scan is the test is completed within a short time. Uh, the stones inside the kidney are obviously well seen, but more importantly, the stones in the ureter, which would otherwise have been missed on an X-ray or an ultrasound, can be seen clearly as well. And some degree of perinephric stranding, which is expected in any patient, can be quantified in grade. If it looks like some urine has seeped out of the kidney because of this intense obstruction, like urinary, this is best seen by a CT scan, and that gives us an indication as to what's to be done next. Also, a CT scan will be able to pick up other cause of pain that could be mimicking a kidney stone. For example, an appendicitis or let's say twisted ovarian cyst are very, very well seen on a CT scan. The CT scan is a plain study. We don't have to inject any contrast, so the risk is practically zero. The only issue here would be, however, that in a young adult female who is probably planning to become pregnant or has an idea that she could be pregnant, we would not suggest a CTKUB. On the other hand, what we would suggest in such circumstances would be at least an ultrasound abdomen, and depending on what we find, we proceed further. Now, the ultrasound is a superb test. It's safe, it's inexpensive. The issue here is that ultrasound picks up the stones which are in the kidney. It might be able to pick up stones which are very adjacent to the urinary bladder, but the rest of the ureter, where most of the stones actually do manage to get lodged and cause pain, might be missed in an ultrasound. So ultrasound might have to be taken in conjunction with an X-ray, and hopefully that will give a picture, if not as good as the CT scan, at least close to the CT scan. It's also important that the ultrasound be done by an experienced radiologist. A CT, on the other hand, does not have is not so dependent on a radiologist for its interpretation. Ultrasound definitely requires an experienced radiologist. So having said that, we get an ultrasound. If possible, we get an X-ray, and we get a CT. Now we have a reasonably good idea as to what the patient has. Let's say a patient now has a severum calculus in the ureter. It is not very big. It's not very small. We typically, the most important criteria as far as the stone management is concerned is usually the size of the stone. You could have a 10 mm stone, you could have a 5 mm stone. You have to realize that the entire tube is about 25 centimeters. The ureter, it starts from the kidney, it comes down into the bladder, it's about 25 centimeters. The upper ureteric stones take a long time for them to come down. The lower ureteric stones, on the other hand, have a significantly shorter time before they get spontaneously expelled. Almost 70% of stones which are in the ureter, especially the lower ureter, provided they are small, do manage to come out without causing further difficulty. 5 mm stone in the lower ureter has almost a 70 to 80% chance of coming out, provided patient has no other major issues. And same 7 mm stone sitting inside the ureter, upper ureter, below the PUJ, below the kidney as we call it, has a much lower chance of coming out spontaneously. It might do it at its own time, and in the meantime, the patient could be having significant discomfort. As I said, the pain can be terrible, and if the stone takes its own sweet time to come down, it can cause progressive damage to the kidney. And AUA, American Urological Association, has given guidelines. Normally, even if a patient is writhing in pain, if provided the stone is not a very big one, they recommend that we could give an observation period of up to 2 weeks from the date of onset of the pain and see if the stone moves out on its own. In the meanwhile, we are encouraged the patient to take plenty of fluids. There are some medicines like alpha blockers, as we call them. There are medicines like tamsulosin or ceridosin or alfuzosin, which help open the urinary passage, and this helps the stone move down with probably a higher chance, much higher chance than what they normally would have done. So let's say a 7 mm stone in the lower ureter, which normally you would expect to have a 65 to 70% chance of coming out. Now you have taken a medicine like tamsulosin for about 10 to 14 days. It has almost a 15 to 20% additional chance of coming out. If it doesn't come out, yes, within 2 weeks if the stone has not moved, then we are justified in going ahead and removing the stone, blasting with laser. On the other hand, sometimes patients do come with the same kind of a 7 mm stone, but they will be having have severe pain. We find that we have given the painkillers, nothing seems to work. We do their other checkups as well. We find that the counts are quite high. We find the creatinine, the kidney function is quite deranged. Now, a mild degree of kidney derangement is expected in these patients. If normally young adult male, a 30-year-old man, as I said earlier, we can call him the index patient. So if he has a 7 mm stone in the lower ureter, his kidney function is something like creatinine 0.9 milligrams, and he's always reasonably healthy, has no diabetes, no infection. Then I'll say, hang on, please wait for about 10 to 14 days at least before we think of whether we should remove it. And as I said earlier, almost 80 to 85% of these patients will manage to pass the stones reasonably comfortably. On the other hand, if the patient already has a creatinine of 1.5, and which is quite high, normal levels would be less than 1.2, 1.3, a young adult pain. The creatinine is high, stone is stacked, he is having pain. It might not really be a great area to wait too long. What could happen is the kidney could get further swollen. There will be some hydronephrosis, as we call it. That's basically the swelling of the ureter and the kidney. And the longer it at this high levels, it basically means that the kidney could get further damaged. So there's something called interstitial nephritis. But if you can wait for about a week or 10 days, provided the kidney function is fine, you're safe. On the other hand, not a great area to do so if your creatinine is quite high. Same thing again with an infection. Let's say a patient is there, he's got only a 5 mm calculus, but he has high grade fever, he's having chills and errors because of the obstruction that this stone has caused. It's not a really good idea to wait and watch. Ideally, you should send this patient's urine sample for culture and sensitivity, start him on some suitable broad spectrum antimicrobials, and then plan accordingly. And the sooner you remove this stone, the better for the system, because an infected system usually damages the kidney pretty fast. A non-infected system usually takes it some time. It might take about a week or 10 days, or as I said earlier, sometimes 14 days. So let's say we have now a 7 mm stone in the lower ureter, as I explained to you earlier. Stone is not causing severe obstruction. The kidney function is reasonably okay. Creatinine is something like 0.9. The counts are something like 8,000, 9,000. Patient says, doctor, my pain has come down. Then we give them medicines like tamsulosin. We ask them to take a lot of fluids. And we tell them to come back in about a week to 10 days, at least definitely before the 2 weeks. Get an ultrasound done, confirm that the stone has indeed passed. If the patient says, doctor, look, you gave me the medicines and I found this coming out of the urinary tract 10 days later, then we know for sure that yes, the stone has indeed come out. If the ultrasoundologist says, doctor, yeah, the stone that was there earlier has now moved, then we know for sure that we are having safe. One of the reasons why I'm trying to tell you this is we come up to the situation where we give medicines, the patient says, doctor, my pain has come down, I'm not going to come back to you again. Have this work, have that work. They leave. Now, unfortunately, if a stone has been stuck for a long time, that can also not cause any further pain. The initial colic episode would be what the patient would have had, and the kidney would be silently going for a damage. And so you need to document, record the fact that the stone has indeed moved compared to its initial level of obstruction. If not, then you are looking at a scenario where the stone will be silently causing damage to the kidney, and 6 months later you find that even if you were to remove the stone, the kidney would not function very well. So it is important that stone having come out should be documented as a part of the treatment process. And one of the reasons why we do tell this is quite a few of our patients, not necessarily only within our country, even across the world, when let's say we have a big stone and we suggest that they should get a procedure to remove the obstruction, to relieve the pain, quite a few people do agree and then get it done. On the other hand, some people would say, okay, maybe let me just try my method. And in good faith, they would probably go to their own family physician. Somebody might suggest some alternative medicine. Somebody might suggest some kind of medicines which they think is part of that. And the patients go home and then they have no pain further whatsoever. And then unfortunately what happens is a year or two later, when they get a health checkup, they'll find that the stone is still stuck at the same location that was done earlier. And we have seen it in countless number of times where the kidney would be silently swollen. The patient would not have realized that the kidney has got damaged under his watch. So it is important that you do get a thorough evaluation, confirm that the stone has indeed passed before you say that yes, you're happy. Now, coming to the situation where indeed there is a 30-year-old man who has a 9 mm calculus. Now, the stone is big, 9 to 10 mm stone, the lower ureter. It is causing him pain. The kidney function is slightly odd. Creatinine is something like 1.3. The counts are something like 14,000, 15,000. then these patients would require what's called an endoscopic intervention. Now, when we say endoscopic intervention, what it usually involves is passing a very, very thin endoscope through the urinary passage and entering the ureter, and we would be able to see the laser fiber actually hitting the stone. Patients themselves can see the procedure, and the entire stone is turned to dust in a matter of a few minutes. And at the end of the process, the patient is absolutely safe. The kidney swelling comes down dramatically well. The kidney function improves fairly soon, and the patient just goes on either the same day or the day after the procedure. This is called ureteroscopic laser lithotripsy. Now, we can have situations where the stone is located in the part of the ureter which might not be accessible by conventional methods, in which case we can use a very thin endoscope, or we can actually go with what's called a stent to ensure that the ureter becomes nicely very dilated. The stent causes the pain to come down, the kidney function does improve. But 3-4 weeks later, the stent is usually removed and the kidney function returns to normal soon after. Once in a while, we do come across the situation where the stone is located either within the kidney or just below the kidney level called the PUJ, and that's a pili-ureteric junction. The stones here need to be handled very, very delicately. Now, it might be easy to trap a stone that is in the lower ureter, but reaching an upper ureteric stone can quite often be a challenge. And then we do have endoscopes, we do have what's called baskets, but trapping a stone within a basket in the upper ureter can be quite risky and might not be really the cup of tea that most urologists would want to be happy with. So what you should realize is, in such a circumstance, the doctor might give you options. The urologist might say, "Doctor, I'm going up there. I will have a look at the stone. If I can blast it with laser, I'll do so. If I'm going to trap it with a basket, I'll be very careful to ensure that I don't damage the ureter. If there's a risk of damaging, then I'd rather not put it in the basket. I'd rather push the stone into the kidney and see if I can blast it from there." So this is called RIRS. RIRS basically means retrograde intrarenal surgery, where a slender endoscope, which actually is flexible, can go into the ureter, go into the kidney from the ureter, and reach each and every part of the kidney, and be able to blast stones which haven't really moved down too much into the lower ureter. On the other hand, the ureteroscopes that are used for RIRS are quite thick and often might not really pass within the normal ureters. So a period of pre-stenting, as we call it, might be required. Something we actually place a stent in position, ensure that the ureter is silently kept safe, and about 2-3 weeks later, once we remove the stent, the flexible scope goes in and can reach each and every part of the kidney. And this is extremely safe compared to the other alternatives. So what are the other alternatives which RIRS has replaced? So sometimes we've had occasion, let's say about 10 years ago, before RIRS was really at its peak, where you had a stone, let's say about 15 millimeters within the kidney, and when the ureteroscopes would not reach the stone, then what we would do is put a small hole to the back and retrieve it through a mini PCNL, as we would call it. Percutaneous nephrostomal lithotripsy. That's what it is, PCNL. So percutaneous means through the skin. Nephrostomy means making a hole into the kidney and keeping it through what's called an applet. It's a hollow tube through which a small endoscope is passed. The stone is seen in front of us. It's blasted with laser or what's called lithoclast, and all the fragments are extracted. Okay. PCNL is a superb technology if the stone is located in a part of the kidney which is not accessible by ureteroscopy, or if the patient has significant infection where ureteroscopy cannot be done. PCNL is a life-saving technology. But having said that, the chances of the amount of PCNLs that we have done over the past 10 years slowly come down. It still has its own advocates, especially for larger stones, which again I'll come back to later. But as of now, a stone like 15 millimeters sitting inside the kidney is now being quite easily approached by what's called RIRS, which is what we are very comfortable with. It ensures that the patients go home in a day or two maximum. The patient has practically minimal pain. Compared to a PCNL where the patients can go home in a day, but there would be some discomfort. They would, after a the first PCNL procedure, we would advise the patient to take it easy, maybe not exert for a week or 10 days, at least after the procedure. The reason why this happens is, officially we are going through the kidney parenchyma. There is a significant chance of damage to our blood vessels. It might be okay now, it might be okay for a couple of days. It might open up and cause bleeding about 10 to 14 days after the first process. And so the risk of PCNL is much higher compared to an RIRS. So RIRS is slowly replacing this method. So you need to discuss with your urologist as to what are the treatment options if you have a stroke, which is not a very big one, located in a part of the kidney, which can be accessed with flexible scope. Having said that, there still are these really big stones called staghorn stones, and you have sometimes stones which are occupying the entire kidney. And any amount of laser is not really going to help because you could be sitting and playing inside the kidney for 1 hour, but if you do a longer procedure with endoscopy and laser from below, then the kidney infection might enter the rest of the body. The patient might end up in what's called septicemia. So when we do have a large stone, large kidney stone, then we suggest that our patients undergo what's called a PCNL. And again, it's a superb technology. It again has come off its own age. What we would do earlier with the big thick endoscopes, now the slender endoscopes have come in, which damage the kidney much lesser than what it used to earlier. But you have to understand that we always keep a couple of units of blood in reserve if we have to do a PCNL. We confirm that the patient is indeed comfortable for general anesthesia. The patient should have a good cardiac status. If he's on blood thinners, the blood thinners need to be off for at least 4 to 5 days before we undergo we ask the patient to undergo a procedure like PCNL. At the end of a PCNL, once we remove all the stone, a tube will be hanging out of the side. Urinary catheter will be left in position for 2 or 3 days. And after 2 or 3 days, the patients usually do go extremely comfortable with too much of pain. But as I told you again, please ensure that after PCNL, the patient should stay back at home for at least a week to 10 days. Confirm that the kidney is healed well before receiving longer. So once we discuss all these options, then the patient says, "Doc, so what do I choose? Can I wait for a few days?" Provided kidney function is reasonably okay, provided there's no infection, we really don't mind the patient going home and discussing with his own family. We would rather suggest that they actually do that. And then the family members are obviously welcome to come and ask us again if there are any further options. Why they think one option is better than others. And obviously, that's the entire idea of needs taking this opportunity to talk to you. So please do understand that there are so many options available. I've not even discussed open stone surgery techniques, but we haven't done anything in the last several years. But we were doing it about 15, 20 years ago, at least 10, 15 years ago, where sometimes with really large kidneys, we would actually split open the kidney, remove the stones. But right now, the chance of really requiring that with the new technologies have become extremely low. So, usually when we do a retroscopy or a RARS or a PCNL at the end of 2 3 days, the patients are extremely comfortable. The pain will be practically minimal. We do leave a stent in quite a few of our patients, but the stent is only a temporary stent. And we suggest that they do come back after 2 to 3 weeks. We get an ultrasound if required before we remove the stent, confirm that the swelling in the kidney has come down. There are no really big stones inside the kidney which require our attention. The stent removal is a pretty short and simple process. It hardly takes about 4 to 5 minutes. The actual process takes about 10 seconds. But usually we do it at the local anesthesia. The patient says, "Yes, doctor, I'm going to cooperate. It's not an issue." And most of our patients luckily manage to go away very, very comfortable. On the other hand, at the end of all these procedures, the commonest question which most of our patients do ask us is, "Doctor, what do I do to prevent this from happening again and again?" So when we have stones, some people develop stones very regularly. They will have probably formed a stone at 15, 16 years of age, and every year on the year they manage to get another stone, and obviously that's tiring for the patients, obviously frustrating for the treating doctor as well. Some people develop stones frequently later. So he might have formed his first stone by around 30 years, but the next stone happens within 6 months, and another 6 months later he forms another stone, and as I said earlier, he again gets frustrated. So these are people who require what's called a metabolic evaluation. Metabolic evaluation would also be recommended for people who have poor kidney function, who have a strong family history of kidney stones, who have only a single kidney by birth or probably by choice. If let's say somebody has had only a single kidney function now because his previous kidney had been operated earlier for some reason, then he has to be extremely careful if he has a 6-7 stones in the kidney. So these are the people who might ask us, "Doctor, can you do something about it? What do I do to prevent my stones from coming back again and again?" So if they have had already an episode of stone surgery, if we have the stone, we ask them to send that for a stone analysis. Okay, we would in that case have some idea as to what we are dealing with. To some extent, after so many years of experience, we do realize at the time of breaking the stone whether we are dealing with a calcium oxalate, monohydrate, or a dihydrate. The dihydrate ones are really soft. Monohydrate will be like a beetle and will be very, very tough. You could have even a uric acid stone, which is golden yellow in color. So we do manage to identify, but it's always better to be documented. And also, you have to realize that a lot of stones actually are mixed. It's unlikely that you will really have a pure uric acid stone or a pure calcium oxide stone. It could be calcium oxide dihydrate 60%, monohydrate 20%, uric acid 20%. And it's important that we know this so that we can formulate a reasonably good treatment strategy. So if we have a stone, we send it for analysis. If a patient has been taking his normal diet and normal fluid intake and says, doctor, I need to know why the stone is happening, then we would suggest that they can get what's called a 24-hour urine stone evaluation. So here, what we will do is the patient takes a container from the hospital. The container can typically hold 3 to 4 liters of urine, and the patient takes his bathroom breaks. As and when he does, he voids into this can, and that can will have a preservative to ensure that it doesn't smell, and he returns it to the lab. So in these 24 hours, how much of urine has come is noted. We check what's the pH. An ideal pH to prevent a stone would be most commonly something like a 6.5 to 7.5. Definitely, acid pH is promoting to the stone. On the hand, some infection stones can thrive even in alkaline pH. In fact, that also is important to be analyzed. So apart from the pH and the volume, we check for whether the filter urine calcium has gone high, is the oxalate high, what about the phosphorus, what about the citrate. Citric acid is supposed to be one of the best preventive methods for kidney stones. If there is something called hypocitraturia, meaning there's low citrate coming into the urine, these patients are more prone for stone formation. So it is important to actually be able to document it. We also at the same time do request our patients to get a blood sample, a few blood tests as well, serum uric acid, serum calcium and phosphorus. If supposing the calcium is high, we might ask them to get what's called a PTH. We do ask, along with, in conjunction with our nephrology colleagues who are superb people, together we can say, identify to a reasonably good extent as what is the disorder, why is this patient forming stones at such a young age, or why is he forming stones so frequently, and then we can think of what are the modalities of treatment. Sometimes you do all this, and out of 100 people, 70 people, you might be able to identify that this is the cause, but 30 times sort of 100, you still not know what exactly is the reason why this human has formed stones again and again. So we can place them on empirical dietary measures, and a lot of people, in fact, are very interested. They do ask almost every time, "Doctor, what do I need to eat next? What do I take for prevention?" And so the most important prevention is water, fluid. Provided there's no dietary advice from any cardiologist or nephrologist who says this so much of water is not good. Ideally, any reasonably good young adult male should take at least 12 glasses of water through the day. And as I said, it's important that you take it through the day. It's taking 6 liters in the morning and have 2 in the evening is not really going to help you. So you have to take it at least about 2 glasses the day the moment you get up, and then every hour on there at least 1 big glass. That will ensure that you pass at least 2 to 3 liters of clear urine through the day, and that's hopefully going to inhibit the stones from coming. Diet is important. However, a lot of people do think that diet is the only thing. It's not. You should reduce your oxalate intake, do advise our patients. But a completely oxalate-free diet is very, very difficult to achieve as well. So oxalate is present in almost every food that's practically tasty. So you ask a non-vegetarian to cut off his meat, cut off his shellfish, and he's going to really feel very, very discouraged. And you ask a younger male to stop his chocolates. Is he going to do that? No. He's probably going to stumble. But yes, it is important that oxalates are kept in limited quantities. But a few dietary guidelines would involve that yes, you restrict your food oxalates in terms of cabbage or cauliflowers or spinach and tomatoes. Don't stop them altogether, but restrict it. Let's say you're taking it 6 times a week earlier. Now you bring it down to maybe once or twice a week. And in vegetarians, sweet potatoes are supposed to be high sources of oxalate, chocolate, peanuts, dry fruits. They are again rich sources of oxalate. So this can be brought down significantly. The non-veg red meat can cause acidic pH and never a good idea for the to indulge in too much of red meat if you're a stone farmer. On the other hand, if you take once a week, I'm not really going to stop you. In fact, it's important that as a young man, you should eat what you want, but everything in moderation is what we would suggest. A lot of people do say that Dr. My this friend who has practiced homeopathy earlier said this medicine to be avoided, that medicine to be avoided. We don't really stop any major medicines. But one thing we do, in fact, in diet, we tell our people that they should take more calcium in their diet. It should not be taken as a supplement. Don't take too many calcium supplements, but calcium in the form of milk products, or buttermilk is actually quite tasty. That goes in, binds to the oxalate in the intestines and prevents it stone from going further. So diet is important. Sometimes we do give medicines to reduce the chance of new stones, but unfortunately we don't have too many medicines. We can give what's called potassium citrate. Potassium citrate has its own side effects. Sometimes potassium can cause gastritis. We do give medicines like hydrochlorothiazide. The unfortunate issue is hydrochlorothiazide can cause electrolyte disturbances. It can bring down the potassium, or it can cause sodium issues. So hydrochlorothiazide also is difficult to tolerate for the young man. They need to take a lot of fluids to be able to take hydrochlorothiazide. There are other medicines to reduce the citrate uric acid from forming. Medicine called febuxostat or allopurinol do work very well, but they need to be monitored. And we would suggest that the patient do come to us, meet us probably once every 3 months, confirm that the stones, or if there are any, are not going further. And if there are no stones are there should be no new stone events, as we call it. So that is in broad a very significant overview of why stones form, what are the present features, how is it managed, how can we prevent it. Obviously, at Kondapur, we have every kind of technology that's available in the world. We have the thinnest of endoscopes, we have the best of flexibility RSS. So if you think at any time that you need advice as far as kidney stones are concerned, you are welcome to meet us and we'll be more than happy to take care of it. I hope this was useful. In case at any time you think you require more, please do send us a message and I'll be very, very happy to get back. Thank you so much.